Yeah, students, hello. For today, we'll be having a class on upper GI bleed. Upper GI bleed is defined as bleeding from the GIT above the level of ligament of treats. Okay, it is classified as per the rate of bleeding. It can be an acute or chronic, as per the source. Can be a variceal and non-variceal, and as per clinical presentation, overt and occult. Mostly for clinical reasons, we'll be taking it as a variceal upper GI bleed and or a non-variceal upper GI bleed. Esophagus. Yeah. First, we'll be taking on causes. Esophageal varices. It is due to portal hypertension. That will be the main cause of bleeding for upper GI, and carcinomas of esophagus, reflux esophagitis, and acute erosive esophagitis or a Malawi rapid triage of hemorrhage in patient while localizing the areas of blood loss is essential for resuscitation and prompt interpretation if an AV is needed, and the patient should be within. Next, I'll be moving on to stomach. The causes will be a chronic peptic ulcer disease, acute erosive gastritis. It can be a drug-induced or a alcoholic gastritis, gastric fundal varices, congestive gastropathy, tumors, radiation gastritis, angiodysplasia, and Dieulafoy syndrome. And duodenal causes. Duodenal causes can be a chronic peptic ulcer, acute erosive duodenitis, a periampullary carcinoma, diverticulum can be a congenital or acquired diverticulum, angiodysplasia, and aortoenteric fistula. It can be acute fatal disease, and bleeding, diastasis, and obscure GI bleed. Clinical features can be acute or chronic, overt with hematemesis and melena, hematochezia, history of drug intake, history of alcoholism, history of peptic ulcer disease, history of jaundice. For any gastric bleed, on examination, patient may have signs of anemia, signs of shock, signs of hepatocellular insufficiency, ascites, jaundice, and signs of liver cell failure like gynecomastia, spironeve, palmar erythema, testicular atrophy. Sometimes it can present as a gastric mass, probably a malignancy, splenomegaly due to secondary portal hypertension and cirrhosis, and pancreatitis and peptic ulcer disease or a perforated gastric ulcer. Adverse prognostic factors can be an age more than 60 years, continued or recurrent bleeding, presence of comorbid condition, severity of the bleeding, and a red nasogastric aspiration, multiple transfusions, and hemodynamic instability. There are two causes for an occult and obscure. The causes of obscure oval bleeding is often common lesion that is missed in clinical evaluation. Repeated upper GI endoscopy and lower GI endoscopy should be performed, and maybe lesions can be identified in about 35% of the patient. Tagged RBC scans and angiography can be helpful. Small bowel enteroclysis with barium or methyl cellulose or air assisted imaging, and being replaced by routine CT enterography. And there are some provocative angiographic testing which involves administration of anticoagulants, fibrinolytics, and or vasodilators to increase the hemorrhage during angiography, which has been employed in small series for favorable reasons, but reluctance to induce uncontrolled hemorrhage has limited its use. Surgical backup and the full availability to salvage the patient in an operating room is essential for planning such a procedure. Type of lesions we will be taking on a need for interventions, endoscopic criteria, stigma, evidence based bleed or ulcer site, posterior bulb, and higher lesser curvature ulcer site. These are some dangerous points which cannot be taken up by endoscopic procedures. Investigation, basic investigation of HB percentage and RBC count, Paxil volume, bleeding and clotting time, platelet count, peripheral blood smear, blood grouping and RH striping, OGD, the most important and useful. And sometimes patient can also go for a thromboelastography, which states the acute bleeding principle of the patients. Immediately after getting the patient OJD, if there is a continuous bleed, requires more than 350 ml of IV infusion per hour to maintain your normal BP. High likelihood of variceal bleed. Technique must be done in operation theater. Crash endotracheal intubation un- under general anesthesia. It can be a diagnostic and both therapeutic. This is an image of an esophageal varices at the lower end of your esophagus, and this is the G junction. This is the J maneuver. You can see the varices extending into the stomach. Okay. This is the OG junction. You can see the slit lip and the large varus which is obstructing and occupying more than 1/3 of its circumference. In case of bleeding, stop spontaneously and respond to simple resuscitation. OGD can be done after hours. OGD finding of risk of further bleed, clot adherence to ulcer base and visible bleeding. USG abdomen, a case of in a case of portal hypertension. OGD negative cases, radioisotope scan with chromium labeled RBCs and selective arteriography in celiac or superior mesenteric artery. General and supportive measures can be, you can start a patient on an nasogastric aspiration to know ongoing bleeding, to remove the blood from GIT, give ice pack cold lavage to reduce bleeding, blood transfusions and fluid replacement, and continuous bleed despite therapy, shock and low hematocrit. And any patient who's put on Ugi Bleed, the first after giving an nasogastric wash, clear and bloody aspirate. If there is signs, Ugi Bleed should be suspected and the patient is stabilized hemodynamically. And then if there is a bilious or a lower GI bleed is suspected hemodynamically, if the patient is stable, patient can be resuscitated and made stable, or the patient can be taken for a CT angiography or a bowel prepared with a colonoscopy. If there is a sign of lower GI bleed, you can go for a bowel prepared for colonoscopy, or if the patient is having complaints of upper GI bleed and signs like hematomesis and melena, you can go for a upper GI endoscopy. The stigmata of liver varices, if it is suspected esophageal varices, then you can go for a balloon tamponade to bridge the stability, or in a intraoperative angiogram. Indwelling urinary catheter to see the output. The expected output to be maintained is 30 ml per hour, which indicates a sign of a adequate resuscitation, foot and elevation, CVP monitoring, and a colonic wash with normal saline and neomycin sulfate for intrarectal lactulose to prevent encephalopathy due to lactulose accumulation. Pharmacological therapy, you can start the patient on somatostatin, which decreases the portal blood flow, splanchnic and vasoconstrictive, octreotide 50 micrograms per hour, slow to reduce the complication of bleeding, and more than 2 hours session, it can be reduced. And complication includes fever, stricture, perforation, mediastinitis. This is a picture of variceal banding. Minnesota tube, balloon tamponade, only in massive bleeding as the pressure increases, and complication has 4 lumens. One on the gastric aspiration, second to inflate the balloon above, and the third is to inflate the esophageal balloon, and the fourth has to aspirate from the gastric thing. This is the sense taken Blackmore tube. This has 3 openings. This will be the this long thing will be the esophageal balloon component, and this will be the gastric balloon component, and this further will be placed in the stomach and duodenal thing to take on any aspirate. Okay. And this tube, one will be for inflating your gastric balloon and the other will be for inflating the esophageal balloon. The gastric balloon can be inflated until 300 mm of Hg and the esophageal balloon is inflated until 40 mm of Hg. It should be released for every 12 hours. If it is not released, it may lead to esophageal necrosis or the thing. And the patient can be put on beta blockers such as propranolol and nadolol for cardioselective to reduce the portal collateral blood flow and also reduces the cardiac output. And all these cases, the patient is put on a selective controlled resuscitation. Prophylaxis, there is no role of sclerotherapy in primary prophylaxis. Pharyngal ligation is more effective than no other treatment. Similar efficacies with beta blockers with more adverse effects, not which is not recommended for primary no, what is it, prophylaxis. Initial protocol includes initiation and resuscitation, tips for a continued bleeding despite of medical and endoscopic treatment, the patient with child C disease and relatively child B disease. It is not useful for portal hypertension for hepatic encephalopathy. The hepatic, the internal jugular to hepatic vein through the hepatic parenchyma through the portal vein, a tract dilator and stented. Steps and complication of steps can be hematoma, cardiac arrhythmia, rupture, liver cell failure, encephalopathy. Overview the treatment of tips. This is a endoscopic therapy like banding and injection of sligosens like polydocanol and surgical splenorenal shunt. A distal splenorenal shunt is used. Surgical treatments aim to stop the bleeding. And for the resuscitation of upper bleed, the protocol of management includes 4 steps. Okay, the first step will be initiation and resuscitation. The first step of management of EJ bleed is airway and breathing. Assess the severity of hemorrhage and by measuring the BP and pulse rate. If the pulse rate is more than 100, there is 20 to 40% of blood loss. Fall in systolic BP less than 90 mmHg. Cold calmary skins more than 40% of blood loss. It signifies. And the hematocrit is not a good parameter to identify the amount of blood loss in acute settings. Start resuscitation with linguractate for about 2 liters. Arrange for packed cells for transfusion and nasal oxygen to oxygenate your tissues and to keep the patient awake. And history of the patient should be asked for melena, hematochezia, history of liver diseases, and drugs like anticoagulants for the use of upper GI bleed can be taken by themselves. And locating the source of bleeding. Rarely, endoscopy within 6 hours has no benefits in stable patients. Recent classification for and early endoscopic definitions helpful and must be unstable patients. Stable patients are recommended endoscopy within 24 hours. A J maneuver or U maneuver is done to examine the fundus for any missed UGI lesions. If an endoscopy cannot diagnose, if there is a massive bleed, angiography will be the second choice to do. If there is an overt GI bleed, an RBC labeled scan can be performed. And step 4 will be a risk stratification score. These scores are assessed for the patients whom we suspect there is high risk of mortality and rebleeding. 2 scoring systems are widely used, one with endoscopy and without endoscopy. With endoscopy we use a Rockall scoring system, and without endoscopy we use a Batchford scoring system. And for Upper GI endoscopy using a batchet will be a blood urea nitrogen, HP, BP, pulse rate, and presence of melena, syncope, liver or cardiac dysfunction. And a Rockall classification, which is using endoscopy, will be age, a comorbid disease, magnitude of hemorrhage, transfusion required, endoscopic findings, and stigmata of recurrent bleed. Bleed risk bleed risk full criteria to predict the risk of rebleed and mortality in upper GI bleeding. Five criteria has been used: ongoing bleeding, low BP, elevated PTINR, and established mental status, and disease associated with liver and thing. Individual upper GI bleeding etiology may be a duodenal cause or other causes. Incidence will be 1 in 1000. Most bleeding stops spontaneously. High risk of recurrent bleeding and increased mortality rate, old age, decreased hemoglobin, shock melena, and need for blood transfusions. The classification for reassessing a rebleeding is by Forest classification. Forest grade A 1A will be a active pulsatile bleeding. This is Forest classification. 1B will be a active non-pulsatile bleeding. Grade 2A will be a non-bleeding visible vessel. Grade 2B will be a adherent clot. Grade 2C will be a black clot. And grade 3. Grade 3 will be no signs of bleeding. High risk of bleeding will be in grade 1 and 2A. Intermediate risk will be in grade 2B. Low risk of rebleeding will be in grade 2C and 3. The treatment and grades: endoscopy must be done within first 24 hours. Immediate treatment is resuscitation, as I mentioned earlier. Endoscopic medical management with anti-ulcer medications or proton pump inhibitors with H. pylori eradication regimens. Endoscopic treatment involves use of epinephrine 1:1000 dilution in 13 ml injected in all four quadrants is effective. International consensus for guidelines, there can be a combined therapy is fully gold standard, and there is combination of epinephrine, electron or organ plasma laser coagulation, which is being used nowadays. And for active bleeding vessel, endoclips is the best treatment of choice. Surgical treatment: 10 to 15% of patients may need surgery. Duodenectomy via longitudinal horizontal incision or 3-point U stitch is done for any mostly a gastroduodenal artery bleed. Okay. To prevent rebleeding, the most common preferred surgery will be a TV with pyloroplasty. Neoplasms: mostly the patient is treated for by surgical resections. Hemophilia: there may be a full communicating tract between the vascular and biliary due to trauma. Liver biopsy, gallstone, hepatic abscess, neoplasms. It can be diagnosed by endoscopy. Blood leak from the ampulla of water, angiography, and treatment by arterial embolization, hepatic artery ligation. Aortoenteric fistulas, always secondary to abdominal aortic reconstructive surgery by thoracic aortic aneurysm, foreign body, neoplasms, the esophagus. Treatment is always surgery. A malarious stir. Laceration in the G junction, 90% has no treatment required. Supportive treatment: endoscopic electrocoagulation, surgical management of bleeding ulcer, a duodenal ulcer, duodenectomy with upper undergoing suture in the pyloroplasty or vagotomy or antrectomy and vagotomy. Gastric ulcers, partial or subtotal gastrectomy or vagotomy. I'll be discussing the other parts in it. Any ulcer in the stomach should be suspected for malignancy, and biopsies from all the quadrants are being advocated now. We go in here. Oops, file access. Yeah. Specific causes of UGI bleed. It can be a varicose bleed. Varicose bleed is from the peptic ulcer. Peptic ulcer is responsible for up to one third of upper GI bleeds and can be developed in the stomach or duodenum. Approximately 10 to 15% of the patients with peptic ulcer disease may develop bleeding in the part of their disease. Peptic ulcer disease results from the imbalance of mucosal barriers and other aggravating factors. The major etiological factors for peptic ulcer disease will be a H. pylori infection, for which the patients. The major etiological factors, as discussed above, worldwide, 77% of the duodenal ulcers are associated with H. pylori infection. The bacterial cause for this is within the mucosa and the impaired mucosal defense and allows the ulcer formation. NSAIDs also disrupt the mucosal barriers, but via different mechanism. NSAIDs inhibit cyclooxygenase COX-1 and COX-2 inhibitor, thus impairing the prostaglandin synthesis, enhancing the neutrophil adherence and subsequent mucosal injuries. NSAID additionally inhibits the release of nitric oxide and also the other things. In the management, the patients can be put on a upper GI endoscopy. And for maintaining, as discussed above, I'll be dealing with the Forest classification. The grade 1 will be an active pulsatile, 1A, 1B will be a active non-pulsatile, 2 comes with A, B, and C. 2A will be a visible vessel, non-bleeding visible vessel. 2B will be a clot, adherent clot. 3C will be a black spot. 2C will be a black spot. Will be a 3 will be a clean, non-bleeding ulcer bed. All the patients with confirmed peptic ulcer disease should receive PPI therapy. Pre-endoscopic high doses of IVP has been associated with decrease in the frequency of high risk bleeding in Forest 1A and 2A, leading to less need of endoscopic interventions. If the PPA has not started prior to endoscopy, a bolus of 80 mg should be given, followed by an infusion of 8 mg per hour for 72 hours. An approach has been reduced the further risk of bleeding and rebleeding and need of surgery and morbidity and mortality decrease rate. And continuing the PPI therapy post endoscopy has also been associated with reduced risk of further bleeding and need of surgery. Interestingly, there is no difference in the outcome of established between oral and IV preparations of PPIs. However, heterogeneity in the study design, PPI dosing, and endoscopic features limit absolute conclusions in the absence of well-designed neo-infertility trial. And there is eradication of H. pylori infection, if present, has been shown in multiple studies and meta-analysis to result in the rebleeding, and there is confirmation of successful therapy should be confirmed by both breath and stool test or by biopsy or by repeat endoscopic. Once H. pylori has been eradicated, there is no need of long-term acid suppression as it does not decrease the rebleed risk. All endogenic medications such as NSAIDs or selective serotonin reuptake inhibitors should be discontinued in favor of alternatives. NSAIDs should be avoided as much as possible, although if they must be resumed, a combination of COX-2 or selective NSAIDs and PPA should be used. Rebleeding rates of COX-2 alone versus traditional NSAIDs plus PPI is similar at 4 to 9%. A double-blinded study by COX-2 plus PPI and showed lower risk when compared to COX-2 inhibitor with selective NSAIDs alone. H. pylori eradication further improves the risk of NSAIDs. A benefit of low aspirin dose for cardioselective or for a for patients with some risk of cardiovascular disease are outweighed in some patients with the risk of GI bleed. In the decision of in the decision to continue an ASA based for its clinical indications for primary and secondary risk, they may be used with other outcomes. Okay. Waiting for all.